So welcome everybody, Happy New Year, and welcome to the General Journal Club of 2019. Today we have one of our St. John Pharmacy residents, Mia Lozier, and she has agreed to do a journal club for us on the POET study. She may or may not have seen in the news, but it's been making waves in the IG community, so I'll hand it over to Mia through the trial. All right, thanks Heather, and everybody. As I said, I'm Mia Lozier, and for those of you who don't know me, I'm one of the pharmacy residents here at the St. John Regional. And today we're going to be talking about the POET trial, also known as the partial oral versus antibiotic treatment of endocarditis, which was published in August of 2018 in the New England Journal of Medicine. Very recently published, but like Heather said, making lots of waves in the community. So some learning objectives for today. Hopefully by the end of today's journal club, you'll be able to describe the study objectives or methods and patient population, describe key findings from the study, as well as appraise the study's and validity. So starting off, is this research question relevant? Essentially, the research here was partial versus oral IV antibiotics. Partial oral versus IV antibiotics for left-sided endocarditis. So what do the guidelines say on this topic? It would be for endocarditis, the American Heart Association 2015 endocarditis guidelines that we would refer to typically. And they may know that typically the treatment for endocarditis is 6 weeks of IV therapy. And the guidelines do have a kind of blanket general statement that oral agents are generally recommended as sole therapy due to their absorption. However, they go into a bit more detail about the use of oral agents, specifically in patients with right-sided Staphylococcus endocarditis, and those and with and IV drug users, so right-sided staph endocarditis in IV drug users. And they say that oral treatment may be an option in this specific patient population if IV therapy is problematic. Specifically, recommend Cipro plus rifampin for uncomplicated right-sided MSSA, and this is based on 2 studies that they. However, they do say that because of high rates of Staph aureus quinolone resistance, this alternative regimen could be problematic. I wanted to take you through the 2 studies that the guidelines do cite in relation to oral therapy. Again, both of these will be for right-sided endocarditis. So the first is Dworkin et al. From 1989, so an older study, very small. It was prospective, but it didn't have any controls with a 4-week follow-up. Essentially, the question that 14 IV users with right-sided non-valvular Staphylococcus aureus endocarditis and no systemic metastases. The intervention here was starting off with IV Cipro and oral rifampin for 1 week, then using both oral Cipro and oral rifampin for an additional 3 weeks for a total of 4 weeks of therapy. In this study, they did find cure rates to be between 76 to 100% at weeks. The guidelines also cite another study, which was a little bit bigger, and it was a randomized controlled trial, Heldman et al. From 1996. Essentially, this trial looked at 85 IV drug users, almost 70% of which were positive, all with right-sided non-valvular Staphylococcus endocarditis and no systemic metastases. The majority of the patients in this study did have MSSA endocarditis as opposed to MRI, which was only 5%, and coag-negative staph, which was 6%. So hence the recommendation guidelines to use this regimen only in the MSSA endocarditis. And here they actually did a complete course of oral antibiotics. So they gave patients oral Cipro and oral rifampin for 4 weeks with a comparison of either IV oxacillin or a combination of vanco and gentamicin, depending on the organism that they were treating. And in this study, they did find some favorable results. So cure were 90% in the orally treated group and 91% in the IV treated group, with a p-value that wasn't significant, so meaning that there was no difference between the two groups. And interestingly, they also found that treatment toxicity was significantly reduced in patients who had received the oral therapy regimen, 60% treatment toxicity in that group versus 62% in the IV treated group, with a significant p-value of less than 5 there as well, 0.05. And I just wanted to highlight as well, this wasn't cited in the guidelines. There is a systematic review on the topic, just for completeness, published in 2014. It included mostly observational studies. 9 of the studies were observational and 2 RCTs. So one of those RCTs I just took you through. The other one is just cited to have a lot of methodological issues. So that's why I haven't displayed it for you here. So is this research question relevant? I think certainly based on this information, it definitely is, just because of the limited RCT evidence on the subject of antibiotics for endocarditis. As well, all of the studies are in endocarditis, so to date there hasn't really been any evidence looking at left-sided endocarditis. Moving on to the critical appraisal of the paper, this again is the POET trial from August of 2018. Was a multi-center, unblinded, randomized, non-inferiority trial. It was conducted in Denmark, and patients were randomized between June 15th, 2011 and August 30th, 2017. The research question that they looked at was in patients with left-sided endocarditis with either of those 4 organisms, so Streptococcus, E. faecalis, Staph aureus, or coag-negative staph. The intervention was to oral therapy after greater than or equal to 10 days of IV therapy. So patients did receive that initial therapy in the trial. A comparator of continuing IV therapy, and this IV therapy was in accordance with the Endocarditis guidelines. And the primary outcome of the trial was a composite, basically 4 major events. So all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia with the primary pathogen at 6 months after completion of the antibiotics. Moving on to inclusion and exclusion criteria, patients needed to be at least 18 years of age to be included in the trial. They needed to have, again, left-sided endocarditis, and this was based on the Duke's criteria. So for those of you not familiar with the Duke's criteria, it's a common, universally recognized criteria to help diagnosis of endocarditis, and it is recommended by the AHA guidelines to aid in that diagnosis. It is readily used, and again with those 4 organisms, so Streptococcus, E. faecalis, Staph aureus, or negative staph. Patients needed to receive that 10 days of IV therapy, and they needed to receive at least 7 days of IV therapy post valve surgery if they did have a valve surgery. And they needed to be stable, so this is kind of a key well. So again, we're looking at patients when they're randomized, they've had at least 10 days of IV therapy. At this point, they need to be stable, which meant that they need to be afebrile for 48 hours. Their CRP need to be less than 10% of the peak value or less than 20 milligrams per liter, and their leukocytes needed to be less than 15 of randomization. And as well, they couldn't have any evidence of abscess on their transesophageal echo or their T. Things that excluded patients from the trial included having a BMI of greater than 40, IV antibiotics for a different indication, having any abdominal disorder, and this was essentially to eliminate patients who might have some sort of malabsorption issues with oral antibiotics, as well as patients with reduced compliance, so make sure patients would take the medications. And I want to touch on the non-inferiority margin in the trial. So this, of course, was a non-inferiority trial, which essentially means that it's to demonstrate that the treatment is unacceptably worse than the current standard. So in this trial, that would mean they wanted to prove that partial oral antibiotics for endocarditis were not unacceptably worse than the current of IV therapy. And this might be a bit of a review for those of you who are at Rachel's journal on fidaxomicin in November. So essentially, when the key word here is not acceptably worse, so you have to decide in non-inferiority trials what an acceptable difference is. And if your results fall within that acceptable difference, then you can claim that the new treatment is non-inferior to the current standard. So in this trial, they chose 10% as their non-inferiority margin, essentially saying that they were willing to accept a 10% difference between the two treatments. Supplemental, they go into a bit more detail about how they came to this this margin. They did use the FDA guidelines, which were published in 2016 for non-inferiority trials. They also considered that the event rate in patients, so the primary outcome event rate in patients who receive IV therapy is quite low. So between 5 to 10% of patients will experience an event when they receive IV therapy. They consider that mortality rate of untreated patients to 100%. So essentially meaning that IV therapy is quite effective in the treatment of endocarditis. They estimated that there would be a large gain from having oral treatment versus the IV treatment in terms of resources and patient-related issues. So one thing to consider in this trial, it was conducted in Denmark. In Denmark, unlike here, for endocarditis, when it's a 6-week IV treatment, they receive their entire treatment in hospital. Here, we'll send people home on IV therapy to receive their treatment from extramural or to go to an IV day hospital to receive their IV medication. So potentially less of a cost savings for us, although certainly cost savings in terms of nursing staff, even from outpatient perspective with an IV versus an oral treatment. And I think if you asked any patient, they would probably prefer an oral treatment over an IV treatment. Certainly can agree with the fact that there might be some patient-related benefits for that. And then finally, they also estimated that there was risk of fatal outcomes that would occur due to failure in the orally treated group. And this is based on evidence that the majority of fatal outcomes that occur in endocarditis actually happen in the first couple days of treatment. In this study, those patients would be receiving IV antibiotics for at least 10 days. So those fatal outcomes, would be affected by switching to oral later on in therapy. As well, patients who received oral therapy in the trial were as outpatients 2 to 3 times a week. So very, very close monitoring in the trial. Maybe not something happen in reality, but that's something that they did to kind of watch for adverse effects. So I also wanted to point out that there was a large amount of patients who were screened for the trial that ended up being excluded. So around 2,000 patients were screened, and only 20% of those 400 patients ended up being included in the trial, which is kind of concerning. So the major reasons for being excluded were meeting the Duke's criteria, willing to consent for the trial, as well as having another bacterial cause of the endocarditis, so not one of those 4 pathogens that were included. But certainly inclusion criteria that the trial used did end up excluding quite a large number of patients. So again, included in the trial was 400 patients. The mean age was 67 years, and 77% of those patients were male. I did want to highlight just a couple characteristics of the patients included in the trial because I think it is relevant. So 38% have valve replacement prior to randomization. 9% had implanted cardiac devices. 6% had prosthetic valve endocarditis, and a very small number of patients included in the trial were drug users, so only 5 patients, or 1.2% of the patient population, which I think certainly having oral treatment would be a benefit in that patient population, but the results of this trial likely don't apply to them since so few were included. And these were the pathogens being in the patients, what the patients had in the trial. So the majority of the infections were caused by streptococcus. So about 50% of all patients included in the trial had streptococcus, followed by Staphylococcus faecalis, Staph aureus, and very few coag-negative staph patients. I think it's also worth mentioning that no patients in the trial had MRSA endocarditis. Although that wasn't an exclusion criteria to be included in the trial, it ended up that just no patients had MRSA endocarditis. So when in the trial, you were probably wondering what were the oral therapies that they used, and they weren't exactly forthcoming information. It was only included in the supplemental. So I've listed them here for your reference, and I've tried to color code just to kind of highlight some of the themes between the regimens and some of the agents that they use for regimens. Essentially, the oral regimens were chosen. They needed to have at least 2 oral antibiotics in each regimen with different mechanisms of action. And from different antimicrobial classes. As well, they looked at pharmacokinetics of the oral agents and looked at MICs for each of the bacteria species. And all of the oral agents that were included of moderate to high bioavailability, which makes sense. And as well, they looked at susceptibilities of the actual agents that they were treating, and they considered that in terms of regimen they chose. So these were the recommended regimens, and you can see here that there's several different regimens. Just to highlight that although these were listed as recommended regimens, the trial supplemental also included what patients actually received. And in addition to these recommended regimens, there was a number of other regimens, of which first is the number of regimens of antibiotics that were used in the trial, which certainly limits our understanding of which regimen would be best to use in this patient population. I will say that probably the most commonly used regimen in the trial was amoxicillin plus rifampin, which you can see for strep, like susceptible strep with an MIC of less than 1 gram per liter. It was also commonly used for the Staph aureus as well. So moving on to the results of the trial, the median time from diagnosis to randomization was 17 days. So essentially that means that patients received a median of 17 days of IV therapy prior to starting their oral therapy, which is a bit longer than that 10 days that was included in the inclusion criteria. I think it's important to recognize that patients received over 2 weeks of therapy, generally 2 weeks of IV therapy prior to switch to oral. In terms of the primary outcome, which again is that composite of those 4 events, all-cause mortality, unplanned cardiac surgery, embolic and relapse of bacteremia with the primary pathogen, occurred in 9% of the orally treated group and 12.1% of the IV treated group, so less commonly in the orally treated group, with an odds ratio of 0.72 and a confidence interval that crossed 1, showing no difference. This meant that there was a between group difference of 3.1 percentage points And the confidence interval for that was negative 0.4 to 9.6 with a p-value of 0.40. So since that confidence interval doesn't cross negative 10, which was the non-inferiority margin that they decided upon, those treatments to be, it met the non-inferiority criteria, so they deemed the partial oral therapy to be non-inferiority therapy. I also want to highlight, because I was a bit confused when I saw the p-value was 0.40, so it's not significant. Because this is a non-inferiority trial, we're actually, if that p-value was significant, it would mean that there was a difference between the two groups. So in this case, not to, like a p-value of greater than 0.05, because it is a non-inferiority trial. And I also do want to say both to treat analysis and a per protocol analysis were performed on the primary outcome, and both of those showed non-inferiority. So if any of you were at Rachel's journal club, she talked a little bit about how in non-inferiority trials you see both of these analyses done. An attention to treat analysis essentially keeps patients in the group to which they were randomized, but in a non-inferiority trial, there's a lot of crossover between the two groups that will lead to a bias of equivalence between the two groups, which you wouldn't want to do in a non-inferiority trial. So it is recommended that done, and both were done here, met the non-inferiority criteria. Some other results that I wanted to highlight, so no patients, they did look at pharmacokinetics of the oral antibiotics. They took some samples from patients at different time points, but no patients required dosage adjustments based on those pharmacokinetics levels, which is good considering the fact that if we were to use these oral regimens in practice, we wouldn't be doing these pharmacokinetic monitoring. So that was good. As well, although it was a small number of patients, so take this with a grain of salt, but there was a significant difference in terms of adverse effects between the two groups. So 6% in the group and 5% in the orally treated group, with a p-value that wasn't significant. So moving on to the study, certainly it was good to see a randomized control trial on this subject, considering the lack of randomized control trials looking at oral therapy for endocarditis. There was really good allocation concealment, so they randomized patients in permuted blocks of 6, and this was stratified based on the site of randomization. So that was good to see. As we talked about, both the intention to treat and the per protocol analysis were done, which is good to see in non-inferiority trials. Moving on to some of the study limitations. It was an unblinded trial. It would be hard to blind from an IV versus an oral treatment, so that's probably unavoidable. There was a small sample size, so 400 patients. And especially if you consider that they had 4 different pathogens, they included both native and prosthetic valves. That further kind of makes each patient population even smaller that they treated. There was no patients with MRSA. Very few IV drug users were included. As well, a variety of different regimens were used, even to the recommended regimens that the trial had. And patients were seen in clinic 2 to 3 times a week as outpatients who were receiving oral therapy, which is wouldn't be what would happen in reality likely, so certain limitation. So applying these results, some information for you guys. Fusidic acid, which was in a couple of the regimens, is actually not available in Canada. The oral form of it isn't available in Canada, so that kind of limits that regimen from us. In terms of NBPDP coverage, linezolid, special auth criteria medication, it's limited to VRE or MRSA/MSSA in patients who can't tolerate IV vancomycin. So I don't know if you could make the case there in terms of using linezolid for these endocarditis patients. Moxifloxacin, special auth criteria medication, although you don't need special authorization if it's written by an ID specialist, which likely would be in the case of endocarditis, so probably not a limitation there. And as well, the other kind of weirder medication or more regular medications that they use in their regimens are a benefit on NBP. So we could those ones. And some other considerations, oral linezolid, from what I've heard, is not very well tolerated. Has a number of adverse effects, including bone marrow and neuropathy and several drug interactions as well. And rifampin is an inducer of the cytochrome P450 system, so a number of drug interactions for rifampin as well. Some limitations to using those regimens for sure. So in conclusion, partial oral therapy is non-inferior to IV therapy for the treatment of left-sided endocarditis, at least in accordance with these trial results. However, the trial did have a number of limitations, and we can't apply these results to anyone with right-sided endocarditis, any IV drug users, no MRSA endocarditis, and no unstable patients, because patients needed to be stable prior to randomization in the trial. So I had prepared. I certainly open the floor to questions and comments, especially if anybody here has used oral therapy for endocarditis, and just to hear your experience with that, or linezolid and how patients have tolerated it. Perhaps I'll bring up the regimens that were used, just for your reference while we do that. Any comments in St. John?
Never. Have you ever seen this? Never.
No, I've seen right-sided. I mean, we do that on occasion. IV and stuff, but no. Sorry, Mia, was there a run-in with IV before the oral switch?
Yeah, so they need to at least 10 days of IV therapy prior to being and in the end, the median time was 17 days. So they got over 2 weeks of IV therapy. So the question here was there a run-in between IV and oral? And we did say that no said that they've really seen anyone switch to oral therapy with left-sided endocarditis, but a couple times with right-sided endocarditis.
Would you expect to see that there will be further studies that shorten that lead-in time?
Yeah, definitely. It will certainly be interesting to see what the next set of guidelines say about this study, but yeah, certainly will lead to further studies on the topic, for sure.
Thank you.
Thank you very much, Mia. And thanks everybody for coming. I'll send out a link for an evaluation this afternoon. If you have a couple minutes to give Mia some, you include your name, I will send you back a CE certificate for your records. So we'll be back the last Tuesday of January, the 29th. Dr. Hull is here to give a diabetes update, so hope to see you guys out for that. Thanks everyone.
Thanks.